Rupture of intracranial aneurysm or arteriovenous malformation AVM. An intracranial aneurysm is an abnormal localized dilatation of the wall of the cerebral artery due to congenital absence of the muscle layer of the vessel. Consistent blood flow against the weakened area results in growth of the aneurysm and thinning of the vessel wall. Aneurysms usually occur in an artery or major branches of the circle of Willis. They may be congenital, traumatic, arteriosclerotic, or infectious origin. Most are secular and asymptomatic until rupture. When aneurysms rupture, sudden bleeding occurs in the subarachnoid space SAS between the arachnoid and the pia, subarachnoid hemorrhage, which produces symptoms of a hemorrhagic stroke. They also may be obstruct CSF flow, cerebrospinal fluid flow, and or prevent reabsorption, decrease blood flow, and or irritate the hypothalamus. The AVM is a system of dilated arteries and veins in which the normal capillary bed is absent. AVMs are described as a tangled mass of discolored vessels that have the appearance of a cluster of grapes. Because of backflow of pressure, a fistula develops, resulting in vascular dilatation and chronic hypoperfusion. Approximately 50% of patients with AVM present with hemorrhage. Other signs of AVM rupture include seizures and signs of mass effect. The Hunt-Hess grading scale is used to determine prognosis and timing of surgical intervention for both aneurysm and AVM rupture. Studies show surgery is the most effective if done before vasospasm occurs. Cerebral vasospasm only rarely occurs in AVMs due to their superficial rather than deep location within the brain. Grading of aneurysms. Hunt-Hess scale. Hunt, Hess, Hess. Hunt-Hess scale. First 0, that means unruptured asymptomatic discovery. First, Roman letter 1, asymptomatic or minimal headache with slight knuckle rigidity. Roman letter 2, moderate to severe headache, knuckle rigidity, no neurologic deficit other than cranial nerve deficit. Roman letter 3, drowsiness, confusion or mild focal deficit. Example, hemiparesis or combination of these findings. 4. Stupor, moderate to severe deficit, possibly early decerebrate, rigidity and vegetative disturbances. 5th, deep coma, decerebrate rigidity, moribund appearance. MORIBUND, moribund appearance. Etiology and pathophysiology. First one, cause unknown or related to atherosclerosis, intracranial AVM, hypertensive vascular disease, head trauma. Second, may become symptomatic due to pressure of enlarging aneurysm on nearby cranial nerves or brain tissue. Third, rupturant hemorrhage into SAS, subarachnoid space, may cause increased ICP, intracranial pressure, and ischemia. Fourth, vasospasm may occur 4 to 12 days after rupture, causing ischemia and infarction. Fifth, rebleeding may occur due to lysis of clot. Clinical manifestations. Sudden onset of severe headache, often accompanied by nausea, vomiting, but no neurologic deficits, may be a warning bleed caused by leaking of aneurysm or rupture of the AVM. Number 2, may present with loss of consciousness and severe deficits if massive bleed. Focal signs or deficits depend on the location of the bleed and compression of adjacent brain structures, that is visual disturbances, cranial nerve deficits, hemiparesis and so forth. Third, other signs and symptoms include visual disturbances, dizziness, knuckle rigidity, photophobia and papilledema. Diagnostic evaluation, history and physical examination. Second, CT scan to determine presence of blood in ACIS. Rule out other lesions. Increased density if blood present may also show increased ICP or mass effect. Number 3, lumbar puncture. If no mass effect on CT, grossly bloody CSF with more than 25,000 RBCs, CSF will not clear with subsequent taps as a traumatic tap would. Fourth, cerebral angiogram, only definitive diagnosis of aneurysm, aneurysmal etiology, documents presence, location and configuration, will also indicate vasospasm. Management. Number 1, intracranial aneurysm precautions to minimize the risk of rebleeding and control BP. Number 2, management of increased ICP with osmotic diuretics such as mannitol. Number 3, antifibrinolytic therapy with aminocarporic acid amicar to inhibit clot lysis and prevent additional bleeding. Controversial. Number 4, management of systemic hypertension with nitroprusside and close monitoring to prevent precipitous drop in blood pressure aggravating ischemia. Prevention of vasospasm with calcium channel blockers such as nimodipine and plasma expanders and hypervolemia to increase cerebral perfusion. Nimodipine has cerebral specificity to block the influx of calcium at the intracellular space. It is the only drug approved by FDA for treatment of vasospasm. Nimodipine is administered at a dose of 60 mg per oral Q 4th hourly for 21 consecutive days from the time of SAH. For optimal effect, the nimodipine should be started within 96 hours of SAH. Fifth, prophylactic seizure management with phenytoin and phenobarbital. Sixth, surgical endovascular interventions to prevent further bleeding. Craniotomy for clipping ligation of aneurysm AVM, evacuation of clot, strengthening of the wall by wrapping if inaccessible to clipping or ligation, endovascular management with detachable coils or balloon angioplasty, aneurysm, embolization with particles or balloon occlusion, AVM, radiosurgery procedures with gamma knife or Linac scalpel, that is for AVM also. Surgical cranial treatment of hydrocephalus with ventriculostomy and or shunt. Complications. The greatest risk for rebleeding is in the first 7 to 14 days after initial bleed. Second, hydrocephalus, obstructive initially requiring ventriculostomy. Non-obstructive long-term may require shunt. Third, cerebral vasospasm, arterial constriction that occurs 4 to 12 days after SAH, which produces decreased blood flow, ischemia and potential infarction. Last one, seizures. Thank you.